My name is Michelle Barrett. I'm the Head of Education and Training Development here at the PCCC. So welcome to the Monday Lunch Live series. Hopefully you've all come to some other presentations that we've been delivering over the last couple of weeks. But allow me to introduce our special presenters today. So we have Associate Professor Michael Jefford. He's the Deputy Head of the Department of Medical Oncology here at Peter Mac. He's also the Director of the Australian Cancer Survivorship Centre, amongst many other hats that I know that this gentleman wears. He has a lot of areas of interest. He's very well published and mostly around designing interventions to improve supportive care outcomes. We've also got Dr. Karolina Lisy, and they're going to do sort of a dual act, I assume, as a presentation of today's session. So Karolina is a Senior Research Fellow at the Cancer Experiences Research here at Peter Mac as well. And her areas of interest are in cancer survivorship and the survivor's experience and needs, and developing and evaluating effective supportive care interventions and models. So obviously a highly relevant area of expertise that Karolina brings to the table. So today they're going to be speaking on a VCCC commissioned study that we did a couple of years ago on the patient-reported outcomes measures, or the PROMs project, as we like to call it. It was a cross-sectional survey which looked at the quality of life of survivors of breast, colorectal, prostate cancer, non-Hodgkin lymphoma or melanoma, and they looked at the 1, the 3 and the 5 year post-diagnosis points and looked at the outcomes from that. So I will throw it over to Michael. You're going to start it off? Okay, thank you so much.
Thank you very much. What I'm going to do is, I'm going to talk for about 25 minutes, and then Karolina will follow with the actual data. I'm going to do the world's longest introduction. So I'm going to say a little bit about what are patient-reported outcomes and to define what we're talking about in terms of who are cancer survivors, and explain some of the, I guess, the debate and lack of consistency around the definition, to talk about the number of people who are cancer survivors in Australia, some of the issues that survivors can experience quite generally, and Karolina will give us the specifics from the VCCC data, and then I'll reflect a little bit on survivorship care, because I think it's important to put this data in the context of clinical care and clinical practice here locally, and we'll talk about some of the issues with current care, as well as some of the work that's been going on locally, including in the state, to try and improve the care of cancer survivors. We'll then shift, I guess, more towards the research angle and briefly review some of the relevant research that's been undertaken by the Cancer Experiences Research group here at Peter Mac. And then I'll hand over to Karolina, who will go through the VCCC data. So what are patient-reported outcomes? Well, there's great expertise in this room, but I think it's reasonable to say that patient-reported measures or outcome measures are anything that's completed by the patient. And that can include measures of symptoms, so that might be fatigue, sleep disturbance, anxiety, depression. It might be about unmet needs, so the need for more information or the need for practical or emotional support. It could be about quality of life that we recognise is multidimensional and could include physical health, mental health, emotional health, etc. It could be measures of satisfaction and measures of preference. And we will have examples of all of those in the two presentations today. And it could be completed in a clinical or a research setting, and they might be completed as a paper-based measure or increasingly electronically, which could be, for example, in an iPad in a clinic. It could be completed on your smartphone, at a kiosk in a hospital setting, and many other situations. And this data could be standalone, or increasingly is linked to an electronic record, which could be a patient electronic health record, or it could be linked directly to the cancer registry. So the second definition is around cancer survivors, and there are various definitions. And I guess in the past we thought of survivors as people who were cured and may have been some years out from their cancer diagnosis. But I think that increasingly we accept the US definition, which came from the National Coalition for Cancer Survivorship, where they were trying to really shift from the notion of a cancer victim to a cancer survivor. And their definitions really indicates that someone is a survivor from the time of diagnosis for the remainder of their life. And they include in this definition family, friends, and caregivers. Now, not everybody likes the term survivor. Some people relate to it and other people don't. And we do use alternate terms, such as living with and beyond cancer. And generally, when we're talking about the survivorship phase, it generally represents the time after initial treatment for cancer. So this is a press release from World Cancer Day last year, when Cancer Council Australia announced or recognised that there are over 1.1 million cancer survivors in Australia. That represents about 4% of the population. These are people who have have had a personal cancer experience. So they may have been diagnosed quite recently or may have been diagnosed 50 years ago. The most recent data comes from Victorian Cancer Registry at the Cancer Council, and the most prevalent groups are survivors of breast cancer, prostate cancer, melanoma, bowel cancer, and lymphoma. And they're the 5 groups that were surveyed in the VCCC survey that we'll be seeing the results of in a moment. Now, I come to this slide and this data because we really, many of you might be going, there's a lot of talk about survivors and survivorship now that there didn't used to be. Why is that? And I guess that the spotlight on the time after cancer treatment was really highlighted when we think about survivors of childhood cancer. And this, the Childhood Cancer Survivor Study has published hundreds of papers on the effects of cancer and cancer treatment. Now, up until about the 50s or 60s, most children who were diagnosed with cancer, the treatments weren't effective and the mortality rates were very high. And now there's been a complete flip. And so almost all children are now cured of cancer, but we recognize that there are consequences of cancer and cancer treatment. And the Childhood Cancer Survivor Study has really shone the light on that. So this was a study, and it was published by Kevin Effinger, who was out here for the survivorship conference that VCCC held last October. And it followed over 10,000 survivors and also 3,000 siblings. And they found that with follow-up, about 2/3 of survivors had developed at least one chronic or long-term condition, and about 1/4 had a severe or life-threatening condition. You might say, we all get other illnesses as we get older, but they compared the experience for survivors with those of their siblings and found that the relative risk of a chronic or long-term condition was 3.3, and the relative risk of a severe or life-threatening condition was 8.2. And the cumulative incidence of a long-term condition with 30 years of follow-up was about 3/4. And I would say, and this I think is staggering, a cumulative incidence of 42% of a severe, disabling or life-threatening condition, or having died as a result of that. So what this is saying is that yes, thankfully treatments are much better. People are being cured, but they also carry the risk of severe health problems. Now you might say, well, that study enrolled people who had cancer between 1970 and 1986. Surely treatments are getting better. And pleasingly they are. And this is a paper from last year's New England Journal, showing that if we look at different cohorts, then treatments are getting better, they're more precise, and the consequences of cancer treatment are reducing, but they're still, it's still a very important problem. Now, when we look at the survivors of adult cancers, and Karolina will give us local data in a moment, there is, I guess, a set of issues that are very common across survivor populations. So whether someone had an experience with prostate cancer, breast cancer, melanoma, a set of issues that are very commonly experienced. They include quite varied reactions at finishing treatment. In some people, it's quite a celebration. For many people, they talk about feeling quite lost and abandoned. And you can imagine that people who are coming into a cancer centre like this, they might be having radiotherapy every day for several weeks, getting a lot of support from a healthcare team, but also from their family and friends. The treatment finishes, and then it's kind of, well, what happens now? There are persisting side effects, and again, we've got local data on that. Emotional and psychological issues, and we know about, many people talk about the worry of cancer coming back. There are side effects that can develop later, which we call late effects, and these are the issues that survivors of childhood cancer experience. They might have damage to organs and the risk of developing another cancer as a result of cancer treatment. There's impact on relationships and family, practical issues like getting back to work and study, loss of income. And I guess that I'd also highlight, though, that many people do report a changed life experience, that this is something that really changes people, and people may benefit from that. And I guess I should say, too, that the vast majority of people do very well after their cancer treatment. So we have to recognize that it's a minority of people that have significant issues. When we think about current post-treatment care, it's tended to be, or historically, medically led, usually face-to-face in hospitals or clinics, and they tend to be brief appointments, where the major focus has tended to be on the detection of cancer recurrence or the risk of developing another cancer. It may involve multiple providers, so people might go and see their surgeon, as well as a medical oncologist, a radiation oncologist, and others. And it may not be, this is perhaps a little provocative, but it may not be evidence-based. And that's partly because we don't necessarily know how often should people be seen, what tests should they have, and that evidence is quite incomplete. But there are some problems with this, and we know that care currently can be quite fragmented and poorly coordinated, and there can be limited attention and limited time given to supportive care issues like symptom control, symptom management, rehabilitation, lifestyle interventions such as helping people to exercise and not to smoke. There can be limited awareness by patients, GPs and others of the potential for late effects and how these might be prevented and managed. And we know that even if our current model was perfect, the growing number of cancer survivors just means that it's simply not sustainable to just keep doing what we're doing. Now, there has been a lot of, I guess, attention to the survivorship phase over the last decade, and it partly came about through this report, which came from the US Institute of Medicine. It's called From Cancer Patient to Cancer Survivor, Lost in Transition. And it really highlighted the issues that survivors can experience and the gaps in medical care and the need for further research. I always plug this video. It's a 17-minute video on YouTube that I encourage you to all watch. That the first time I saw it, I thought it's so American, but then I thought, you know what, most of the issues are just the same. They might have the American accents, but it's a similar set of issues. So the IOM report talked about key components of post-treatment care. They talked about the need around prevention. So we need to be able to prevent recurrent cancer if we can. We also want to be able to prevent late effects. So if we can prevent people from developing infertility or prevent people from developing heart damage as a result of cancer treatments, then we should be doing that. We need to think about surveillance, not just for the possibility of cancer coming back, but also for the known medical and psychosocial late effects that people can experience. We need to be intervening to deal with the problems that people have. That might be medical problems that are listed here, like lymphedema and sexual dysfunction, symptoms such as pain and fatigue, distress that we know can be just as common in caregivers and family members as people directly affected by cancer. And we need to help people with employment, insurance, disability, and we've got to make sure that all of this care is well coordinated. So there were a set of recommendations from the IOM report. I'll just briefly go over those. 10 recommendations. The first was about raising awareness about the survivorship phase, the issues for survivors, and the fact that we've got to be thinking about how do we do this better. There was a high-level recommendation around survivorship care plans, which basically giving people information about their cancer diagnosis and treatment, and plans for follow-up, strategies to remain well, symptoms to look out for, and ways to get back into the system and to get support. They talked about the need to develop evidence-based guidelines and to ensure that these are implemented. And I guess related to that, that we need to establish quality measures and make sure that we're adhering to those. We need to think about different models of care, recognizing that our current model of care isn't sustainable. We need to make sure that survivorship is embedded in cancer control plans, and it is embedded in our Victorian cancer plan, and I'll come to that in a moment. We need to educate health professionals, make sure that people aren't discriminated in terms of employment and access to healthcare, and there's a lot of research that we need to be doing, and we'll come to that too. So recognizing that we need to be doing more to improve care for cancer survivors, excuse me, At Peter Mac, we were keen to establish a centre, and in 2009 we were lucky to receive funding from the State Department of Health and also the Pratt Foundation to establish the Survivorship Centre, which also has core funding from Peter Mac. As a result of our dual focus, we do have dual funding, sorry. We have a focus both on Peter Mac and the precinct, but also much more broadly and the whole state. We're a small team, which punch above our weight, but we're a small and highly effective team. And our goal is to support and to enable excellent survivorship care. We have a current strategic plan and we'll soon release our new strategic plan. You might be able to see there that it says that our purpose is to support and to enable excellent survivorship care. We have 6 broad areas of focus, and this will be the same in our new strategic plan. And they're broad, I might just go through that briefly. So we want to ensure that survivors have access to information and support, and we know locally that people talk about a lack of information and support. We want to enable excellent care here and in the precinct and across VCCC. We want to increase the capability of survivorship care to be provided in the community. We want to build a sustainable program to advocate for enhanced survivorship care broadly across the health system and to develop and to disseminate the evidence base. So briefly, just some highlights of some of the work that we've been involved with. Recognising the need for more information and support, we have worked to fill some of the gaps. We've certainly not wanted to duplicate the excellent work that's being done by Cancer Council and other organisations. So we've aimed to supplement information. An obvious gap was that there was little or no information for people who speak languages other than English, and we've completed work for the language groups that are listed here and working on other area language groups as well with funding from Cancer Australia. We run face-to-face workshops in partnership with Cancer Council. We've developed a number of survivor stories, and we work with many other organisations, recognising that improving survivorship care is part of what these listed organisations are interested in, but many others, and also the fact that we're a small team and we have to work with other partners. So, as I said, a very long introduction, but so these are just a few examples of some of the information that we've developed for patients, survivors and carers. So on the left, an example of information that's disease specific, so follow-up of survivors with, who've had an experience with bowel cancer. The middle one, which is questions that you might like to ask your healthcare team, and on the right, an example of more detailed information about a common post-treatment symptom issue, which is dealing with cancer-related fatigue. Some of the examples of the work that we've done in developing information for people who speak other languages. Very obviously, they're branded as Cancer Council resources because we're aiming for national distribution. An example on the top of a resource that we developed for people who speak Vietnamese, which is in both English and Vietnamese, and the lower one for Arabic speakers. So moving to education, we recognised that when we began that one of the first things that we did was we asked a broad range of health professionals about whether they felt that providing survivorship care was part of what they do. And this was GPs and nurses and allied health and a variety of medical professionals. We also asked, do you feel that you have all of the knowledge and skills you need to provide excellent care? And pretty much everyone said, this is part of what I do, but I could do with more education and training. So we've been involved in a number of areas. We've developed new written information. We developed an online training module, which I'll show you in just a moment. We run regular face-to-face training, and we've run a placement program for GPs and practice nurses, initially at Peter Mac, and then with further funding from the department to run that at multiple sites in Victoria. And we also convene a community of practice for the state-based survivorship program that I'll come to in a moment. Again, just some examples of the information that we've developed for health professionals. This is the online training that, again, we're looking for national distribution of this, and so that's being hosted by Cancer Learning through Cancer Australia. We've written about the development of that module, and we've also published about the placement program as well. So this is just a snapshot of some of the work that the Survivorship Centre has been involved with, but there are obviously many other people who are interested in improving survivorship care broadly, including at Peter Mac. We have a late effects service that a large group of people who attend that are adult survivors of childhood cancer. We've got a number of, and we're thinking about different models of care. We've got a number of nurse-led clinics here at Peter Mac, a focus on prehabilitation to ensure that people can be as well as they can be at the beginning of their cancer treatment. It's probably too late to be thinking about issues for survivors when they've finished their treatment. We've got to be thinking about that very early. We've done quite a lot of work about trying to implement survivorship care plans here, and as I mentioned, the placement program. Just a couple of papers about our local experience of implementing care plans here at Peter Mac. The short answers to conclusions of that is that they're really valued by patients and survivors. And we have to think about how we embed this into usual care and our processes so that it's actually achievable. Other work in the precinct, I think that just a couple of examples, a project on follow-up of women with early-stage breast cancer that's been led by Professor Bruce Mann. And that thinking about different models of care, that includes a nurse-led clinic component as well as shared care with general practice. A similar project that was led by Orla McNally for women with endometrial cancer at the Women's Hospital. And as an example of symptom-based focus and symptom-based clinics, Martha Hickey runs a menopause clinic, and I think it's a great example of that we might be thinking about some multidisciplinary symptom-based clinics, not perhaps for everybody, every survivor, but perhaps for people with difficult and more burdensome or problematic issues. So just to say that or I should go back a slide, at the bottom of the Peter Mac website, you'll see a link for Australian Cancer Survivorship Centre. All of the resources and all of the projects that we've been involved with are on the ACSC website, or you can get to that at petermac.org/cancer-survivorship. So, thinking a little bit about the Victorian program, the Department of Health and now Department of Health and Human Services has had a significant and long-standing commitment to improving survivorship care across the state. And in the previous cancer plan, there was a major commitment to exploring new models of care. And in the period from 2011 to 2014, there were 6 projects that, one of which was the one that I mentioned that was led by Professor Bruce Mann. And these were projects looking at different, which were deliberately diverse. So they included people with different cancer types, different age ranges, metro and regional, and different models of care. And 3 of those projects are ongoing and that have extended to other sites. And in the current cancer plan, again, a major commitment to exploring new models of care and providing better care for survivors. And to date, $3 million has been spent and allocated, and another $500,000 that will be announced, well, has been announced, and the projects, we believe, have been reviewed, and we're hoping that they'll be announced very soon. So many of you will be familiar with the current cancer plan, and within that, as I said, a commitment to support cancer survivors to recover and to thrive. And I won't read all of this, but at the beginning, as you see, a focus to implement survivorship programs to support people in their recovery, to reduce and manage the consequences of treatment and achieve better long-term quality of life. So I think that we have a major commitment in Victoria, perhaps more so than the rest of the country, and a significant commitment internationally. So just now focusing a little bit on research, and then I'll lead into Karolina's presentation. On the Peter Mac website, if you hover over the research and discovery section, there's a section on clinical research, and within that you can see that there's a section on cancer experiences research, and again within that some of the work that we're interested in the survivorship and living well program. So just very briefly to give you a sense of some of the work that we've been involved with over the last 10 years. It was about 10 years ago that we began this work, and we began by doing focus group work with Australian cancer survivors, with carers and health professionals, really to determine are the issues that we hear about in the literature the same for Australian survivors, and the short answer is that they are. And we used that work to inform both the first Cancer Council booklet on survivorship and also an evidence-based DVD, which was funded by the Peter MacCallum Cancer Foundation. We then went on to, survivorship care plans were quite new, and we went on to try and understand the views of survivors and health professionals about care plans and about follow-up. And that led us to pilot a nurse-led supportive care package for bowel cancer survivors. We then developed that as a randomised controlled trial that was funded by Cancer Australia and the Victorian Cancer Agency. And we've completed that study and published the middle one. It was the baseline data, and the bottom was the final results that we published last year. And whilst we were doing that, we were involved in another study that was led by John Emery, who's based here, but DISA was very much involved in the study. And that was looking at another model of care, which was a randomised study comparing usual hospital-based follow-up for men with prostate cancer with a shared care model with general practice. And again, that's been completed and published and has informed practice locally, and we're seeing shifts in practice in Melbourne. Finally, as another example, Phyllis Buto led a couple of studies that a few of us here were involved as investigators with, which were looking at patient-reported outcomes in migrants with cancer. These were a couple of studies that were funded by both NHMRC and Cancer Australia, finding that migrants with cancer report inferior quality of life and more problems with psychological well-being, and that's led us to a number of interventions for survivors from migrants with cancer. So that's just a taste of the work that we've been involved with in cancer experiences research, and much of it does relate to patient-reported outcomes. So it was a very long introduction, but I hope that that gives you some of the clinical and the research context that will lead to the discussion that Karolina will describe. So Karolina completed a laboratory-based PhD which relates to oncology, but it's a little bit of a stone's throw from the work that she's doing now. And then moved into public health and evidence-based healthcare, and knowledge translation, making sure that we do implement evidence-based strategies in healthcare. And Karolina has recently joined us in cancer experiences research here at Peter Mac, and has been heavily involved with the work that, as Michelle said, was commissioned and funded by VCCC. So I'll hand over to Karolina, who will go through the data from the PROMs study.
Thank you, Michael. So my name is Karolina, and I'm going to talk to you today about the recent study that was funded and undertaken by the VCCC, and that collected population-wide patient-reported outcome data for cancer survivors in Victoria. So a little bit of background to the project. As Michael said, there is a need to improve cancer care for cancer survivors. And in order to improve care, we first need to understand the experiences and needs of the survivors themselves. The collection of patient-reported outcomes from a population-wide sample of survivors can describe their self-reported experiences, their quality of life, symptoms and needs, and can be used to inform supportive care interventions and models of care. There is currently a lack of this kind of robust population-based data regarding the lived experience of cancer survivors internationally. In 2011, the National Health Service in England conducted a pilot survey to assess the quality of life of cancer survivors nationwide using patient-reported outcomes. And it was the largest such study at the time to have been conducted to collect patient-reported outcomes from cancer survivors. And they focused on the 4 cancer types listed here, which are breast, prostate and colorectal cancer, and lymphoma. So based on the success of that work, the VCCC aimed to undertake a similar study, and the aims of this study were to assess the overall quality of life of representative samples of cancer survivors with a previous diagnosis of either breast, prostate or colorectal cancer, lymphoma or melanoma. And we were interested in looking at 3 different time points, so 1, 3 and 5 years post-diagnosis. We further aimed to investigate the contribution at different variables, such as demographic variables of age and gender, and also disease-related factors, such as response to treatment, have on quality of life. So briefly to go over the methods, eligible cases for our study were identified from the Victorian Cancer Registry, and for this study to be eligible, we wanted a previous diagnosis of the 5 cancer types we were interested in at 1, 3 or 5 years prior to the study. Participants had to be adults, so aged 18 years and over, and be a Victorian resident at the time of their diagnosis. So this was a postal survey, and patients were sent the survey and an information sheet and a reply paid envelope, and we aimed to have about 128, or exactly 128, patients in each sample for each cancer type and each time point. And our comparison data set was a general, was patient-reported outcomes or an equivalent survey done of a general population sample from 2011. So the survey contained a number of validated patient-reported outcome measures, and I'll go over a few of them now. So we looked at overall quality of life as measured by the EQ5D5L. So this is a generic quality of life tool that assesses quality of life according to 5 domains that are listed of mobility, personal care, usual activities, pain or discomfort, and anxiety or depression. And it assesses these over 5 levels, so from no problems to I am unable or extreme problems. We also included measures that were specific to each of the cancer types. So the example here is the FACT-C, which is the Functional Assessment of Cancer Therapy colorectal cancer module, which also assesses quality of life over 5 levels of not having any difficulties and having very, very much difficulty. We looked at the social difficulties inventory, which looks at 21 items related to social distress at 4 levels of no difficulty to very much difficulty, and also included individual items related to symptoms that were experienced, unmet needs for information, disease-related factors such as self-reported response to treatment, presence or absence of other serious health conditions, and care-related factors such as having a written care plan or perceived satisfaction with care. So most of my talk is going to be on the results of this survey, and I've split the talk into 3 different sections. So the first section is going to look at the overall results, comparing the 5 cancer types. And then I'm going to talk specifically about colorectal cancer. So our plan with this data is to look at each individual cancer, and I've chosen colorectal cancer as an example. And then I'm going to talk about a further analysis that we did of the data according to sexual orientation. So this is the first of many data slides. This talk is very data heavy, so I'm not going to spend a lot of time on some of the slides. This one is simply to demonstrate the response rate. So we had a 45% response rate, so we had 2,115 respondents, and there were no systematic or consistent differences between our eligible cases and our responding cases. So looking at quality of life across the 5 different tumour types, this table shows the percentage of survivors reporting any level of problems with the quality of life items. And I'd like to draw your attention to the bottom here, which compares outcomes for all groups, so any cancer survivor and the general population. And you can see that across each of the domains, cancer survivors experience inferior outcomes, particularly in the domains of usual activities and also anxiety and depression. So anxiety and depression, 35% prevalence in the survivor population and 22% in the general population. I haven't finished with that one. So we can also see that breast and colorectal cancer survivors have reduced quality of life compared to the other cancer types. So the comparisons that were made here were between each cancer type and the remaining cancer types. So breast cancer compared to colorectal, melanoma, lymphoma and prostate cancer combined. So comparatively, breast cancer survivors experience more pain and discomfort and anxiety and depression. And problems with mobility and personal care and usual activities are more prevalent in colorectal cancer survivors. And we can see that conversely, melanoma and prostate cancer survivors experience fewer difficulties. So specifically, 4% of melanoma survivors experience difficulties with personal care, and that's equivalent to those experienced by the general population. So I'm now going to describe the results of the social difficulties index. So this is an example of what the measure looks like so that you will understand what I'm going to show you on the next screen. So there are 4 different categories. So we've got a category for everyday living that looks at measures of personal care, family, recreation, and money matters, which looks at finance, access to benefits and work-related issues, self and others, so communication, body image, isolation, and then a number of single items relating to sexual matters or plans to have a family. The 3 top measures receive a score, and then the score of those measures combined gives an overall social distress score. So we're not looking at the prevalence of problems anymore, we're looking at an average score of SDI for the SDI across the cancer groups, and here a higher score indicates greater difficulty. So once again, we can see that breast and colorectal cancer survivors experience greater social difficulties compared to the other cancer types. And once again, melanoma and prostate cancer survivors experience fewer social difficulties compared to the other cancer types. So here we wanted to investigate the relationship between various factors and generic quality of life as measured by the EQ5D5L. So here we have the results of a regression analysis that was conducted, looking at a range of different variables, so response to treatment, having a written care plan, the different tumour groups, and demographic factors such as age at diagnosis, gender, language spoken at home, and the year since diagnosis. So once again, red here indicates a statistically significant negative effect, and we can see that having a long-standing health condition was significantly associated with a decreased quality of life. And we can also see that having a cancer that has not responded fully to treatment is also associated with a statistically significant decrease in quality of life. Cancer survivors that responded other than, yes, they definitely had a written care plan, also had diminished quality of life. And we can see that compared to the other tumour types, having melanoma was associated with a slightly increased quality of life. And being female was seen to be associated with a decreased quality of life also. Interestingly, language spoken at home had no relationship to quality of life in our model, and age at diagnosis also had no impact. So now I'm going to discuss some symptoms issues that were experienced by survivors at 1, 3 and 5 years. So I'm not going to go over all of this data, but here we see the percentage of respondents answering strongly agree or agree to having one of these symptom items. And we can see, looking at breast cancer survivors, they seem to have, the symptoms are experienced at the highest proportion in breast cancer survivors compared to the other cancer type survivors. We can see that at 1, 3 and 5 years, approximately 50% of breast cancer survivors experience fear of recurrence. So that's a really high proportion of breast cancer survivors still experiencing fear of recurrence at 5 years. Similarly, 50% of breast cancer survivors experience trouble sleeping right through to 5 years. Between 40 to 20% experience difficulty concentrating, and fatigue, also 40 to 50% of breast cancer survivors experience fatigue at 1, 3 and 5 years. And that's not to discount the proportion of survivors of the other cancer types also experiencing these symptoms. So you can see across the board a really significant proportion of survivors of all of the different cancer types that we looked at experience these symptoms at 1, 3 and up to 5 years post-diagnosis. So here we are looking at information needs. So this table shows the percentage of positive responses to the question, would it have been helpful to have had more advice or information on any of the following issues? So the top box indicates respondents that said, I have all of the information that I need. We can see that for all cancer types and across all years, about 50% of respondents answered positively to this question, which indicates that half of all survivors did not have all of the information and advice that they needed. Looking at the domains of information needs that were not met, physical, psychological and emotional aspects of living with and after with cancer represent the greatest area of unmet information need, followed by diet and lifestyle and physical activity and exercise. Information on financial help and benefits, cost of prescriptions, work, information and advice for carers and family members, information about support groups and pain management were all experienced at a much lower rate, so about 10% people take across all years and for all cancer survivor groups. So in conclusion for the cancer comparisons data, we see that survivors generally reported inferior quality of life compared to the general population. We also see that survivors of breast and colorectal cancer tend to have inferior quality of life, and that survivors of prostate cancer and melanoma tend to have slightly improved quality of life when we compare the different cancer types to each other. Symptoms issues such as trouble sleeping, trouble concentrating, fatigue, and fear of recurrence are prevalent across all cancer groups and persist for many years. And also, all cancer survivors experience significant unmet needs for information. So I'm now going to discuss the specific results for colorectal cancer. Once again, this table is to show the difference between the eligible cases and the responding cases. Our response rate was 45%, and there were no systematic differences between the two groups. So for quality of life of colorectal cancer, the comparisons that you're looking at now are not between cancer types, of course, they're between different years. So here analyses were done to compare the group at 1 year to groups at 3 and 5, etc. So we can see that compared to the general population, the combined cohort of colorectal cancer survivors experiences diminished quality of life across all of the domains. So there's a higher proportion of survivors reporting problems with all of the domains compared to the general population. The statistically significant results are indicated in red, indicating that at 1 year, more survivors report problems with pain and discomfort and anxiety and depression compared to 3 and 5 year cohorts. And the other problems seem to be equivalent, sort of the prevalence of the other problems are roughly equivalent at 1, 3 and 5 year cohorts. So that was generic quality of life. We also, as I said, looked at disease-specific quality of life. So this is the results of the FACT-C questionnaire. And I've split the responses here into participants that said they had no problems, participants that said they had a little bit of problem, and participants that said they had quite a bit or very much difficulty with each of these items. So I'm going to highlight a few that show significant difficulties. So looking at the first one, quite a high number of survivors report problems with swelling and stomach cramps right through to the 5 year cohort. So about 25% of survivors at 5 years report having at least some difficulty with swelling and stomach cramps. Control of my bowels. So we can see about 20% of colorectal cancer survivors report having no control of their bowels at all time points. And same with digestion, just under 20% of colorectal cancer survivors report not being able to digest their food well at all. Diarrhea is also quite prevalent in this group, so we can see that at 5 years, nearly 40% of colorectal cancer survivors report some problems with diarrhea. And looking at the psychological aspects of the fact C, we can see that body image is also a significant problem. So only 13% of colorectal cancer survivors report liking the appearance of their body. And also 10% of colorectal cancer survivors at 5 years are embarrassed by their ostomy or stoma appliance. Looking at social difficulties, I've put the average scores for each of the scales on the right, but I've also here broken it down into the individual items that make up the SDI. So we can see, according to the weighted mean scores, that difficulties with the social items in the scales decrease over time. So between 1, 3 and 5 years, we see a consistent decrease across all of the scales. And looking at the individual items within the scales, we can see the items which people have the most trouble with. So domestic chores and recreation, body image and social isolation, sexual matters and holidays. And looking a little bit closer at the sexual matter item, we split the results according to the location of the cancer. So split survivors based on having colon cancer or rectal cancer. And we can see that at 1 year, twice as many rectal cancer survivors report problems with sexual matters than colon cancer survivors. Symptoms experienced by colorectal cancer survivors, so this is the proportion of survivors reporting that they strongly agree or agree with the following symptom items. You can see that fear of cancer spreading and fear of recurrence are the most often reported symptoms, and they occur at 39% and 53% at 1 year and decrease by about 20% at 3 and 5 years. But looking at the other symptom items, so trouble sleeping, trouble concentrating, and always feeling tired, we can see that a third of colorectal cancer survivors experience these symptoms at each time point. So to conclude the colorectal cancer data, colorectal cancer survivors experience inferior quality of life outcomes and persistent problems with mobility, anxiety and depression, and performing daily activities and personal care. Survivors also experience difficulties with sleeping, concentration, memory, fatigue and fear of cancer recurrence up to 5 years post-diagnosis, and problems with body image and social isolation, and specifically for survivors of rectal cancer, problems with sexual matters at 1 year post-diagnosis. So now I'm going to talk about patient-reported outcomes for sexual minority cancer survivors. So why are we interested in looking at this patient group? So first of all, sexual minority in this talk is defined as lesbian, gay, bisexual, transgender or intersex, and I'll use the commonly accepted acronym LGBTI to describe that for the rest of the talk. This group is at higher risk of some cancers, and they also have a reported vulnerability to poor psychosocial outcomes. And they also represent a largely understudied cancer survivor group. Our survey included an item on it that asked for patients to self-identify as LGBTI, and they could choose to respond yes, no, or prefer not to answer. So looking at our results, we can see that only 1.6% of respondents identified as LGBTI, which is not a lot and is about half that estimated for the Australian population. We also see that 4.2% chose not to answer the question. So we had a really small sample size to work with for our analysis. Interestingly, looking at the age groups of those that identified compared to those that did not, we see that those that identified are significantly younger than those that either did not answer the question or that identified as heterosexual. So looking at the patient-reported outcomes for this group, we see the percentage of survivors reporting problems with quality of life according to sexual orientation. There's not a lot of difference between groups. So to walk you through the first table that you see. The question on the left is, do you identify as being LGBTI? And the results are split according to those who answered yes and those who answered no. And all of the data for this section is going to be presented that way. So those that said yes to that question, we can see going right across to anxiety or depression, 45% of those that identify as LGBTI who experience depression, compared to 22% of the general population and 35% of all respondents. So this is not statistically significant, but it does indicate perhaps there is a trend towards increased anxiety or depression in this group. Personal care, so there's an A next to it, that refers to, it was a p-value of 0.07, so not quite statistically significant, but we can see a trend towards less or fewer problems with personal care in the LGBTI group. Looking at the social difficulties index, again, these are the average scores of the index. There are no significant differences between those who identify as LGBTI and those that do not. So we also probed the social difficulties index a bit closer to look at each individual item and did find some statistically significant results within it. So highlighted in green are outcomes where the LGBTI group had favourable outcomes. So in terms of financial services, they had fewer difficulties, 8% versus 18%. And in terms of communicating with those closest to them, they also had fewer difficulties, reporting 12% versus 22%. So while, again, not statistically significant, they appear to have, the LGBTI group appears to have fewer financial difficulties, so 14% compared to 22%, and increased difficulty with financial benefits, so 36% compared to 21%. And also perhaps slightly more problems with body image, so 42% compared to 30%. Looking at information needs, we can see that those that identify as LGBTI have greater information needs for diet and lifestyle, and fewer information needs regarding information about support groups. And we also did a comparison of those that responded yes and no to this question and their experiences of care. So here we see that those that identified as LGBTI are more likely to have an age nurse that they know to contact about their care. And they're also more likely to answer yes to the question, do you think the GPs and nurses do everything they can to support you following your cancer treatment? And with a p-value of 0.051, they also respond yes more often to the question, do you think hospital staff did everything they could to support you following your cancer treatment? So to conclude on that section, our data indicate there's no real difference in quality of life for people based on their sexual orientation. However, there is a possible trend towards less difficulty with personal care and more difficulty with anxiety or depression. The LGBTI group have fewer financial concerns and fewer communication problems, and less need for information on support groups, but greater need for information on diet and lifestyle information. So I must say that these results are somewhat at odds with the international literature, which often show inferior outcomes for the LGBTI group. So our study is obviously limited by a small sample size and confounded by the younger age distribution of the LGBTI group. It's also possible that it's been confounded by a number of other factors, such as younger people having higher health literacy or self-efficacy, or often LGBTI groups might be more educated or exist in higher socioeconomic groups. It's also possible that generic quality of life tools might not appropriately capture the outcomes for this population. So to wrap up the talk, This study conducted by the PROMs represents the first population-wide patient-reported outcome study for cancer survivors in Australia, and we have demonstrated significant issues across quality of life, symptoms, issues, unmet needs for cancer survivors of the 5 most prevalent cancer types in Australia that persist for up to 5 years. So clearly there's a lot more work that needs to be done here to address those issues. So some further questions that are thrown up by this study. What are the issues that contribute to a reduced quality of life? So we've got some suggestion here. And how do we best identify people who are at risk of having inferior quality of life outcomes? How do we prevent and manage symptom issues or the physical or psychological impact of cancer and its treatment? And as Michael talked about also, what are the underlying mechanisms behind some of these late effects? And finally, what are effective and sustainable interventions and models of care that we can implement to address these gaps? So internationally, there is an increased interest in the routine and ongoing collection of patient-reported outcomes, and also in integration of this into electronic medical records. And based on the results of our study, I think that we support, or our findings support, the initiation of a similar strategy in Australia. So I'd like to acknowledge the PROMs for funding and undertaking this work, and the Social Research Centre for conducting our statistical analyses, and everyone listed on the slide. Thank you.